Diabetes 101 for behavioral Diabetes 101 for behavioral health specialists, understanding the basics of diabetes prevention and management. This is a webinar that is part of a webinar series. In a moment, we are going to share the registration link for the second webinar. Today, we are just going to briefly discuss the basics of diabetes. As you know, diabetes is a very complex chronic medical condition that requires a lot of understanding in regards to the pathophysiology, the complications, and the signs and symptoms. And there is a lot of updates every year. You can get updates from different organizations about this condition. The American Diabetes Association has the standards of care, and every year they make sure that the most recent recommendations are added to the standards of care. So this is a learning process for all of us, not only for clinicians, but for any other who is somehow involved in the care of patients with of people with diabetes. That is a new term, or the terminology that is being used. Instead of saying patient with diabetes, they now prefer to say people with diabetes. And you can find those new terms or the terminology in the new standards of care. So I am very pleased that today we are going to have Dr. Kevin Lombardi, who is an MD and an epidemiologist, who will be briefly discussing with us the impact of diabetes on public housing residents and those people receiving assistance from HUD. So next slide, please. Some housekeeping items before we get started. At this moment, all participants are muted. If you have any questions, you can type your question in the chat, or if you prefer, you can use the raise hand icon at the bottom of your screen, and your line will be unmuted. The meeting is being recorded, and the slides and recording and links and resources will be sent to you via email few days after this webinar. Next slide, please. We have a poll question. Can you please describe the type of your organization? Either you are with a health center, with a nonprofit organization, with any other safety net provider organization, or a primary care association, or any other organization that you see on this list, a public housing agency, or of a local or state health department. We are going to give around 30 seconds for you to answer this question. All right, Fite, can we close poll, and can you please provide us with the results?
Sure. So far we have 72% of participants from health centers, 10% are from nonprofit organizations, another 10% from primary care associations, 4% for local and state health departments, and 2% from a government agency, and also 2% from other.
Excellent. Thank you so much, Fide. We have a participant from different organizations. We appreciate you're taking the time out of your busy schedule to join us. Next slide, please. The National Center for Health in Public Housing is supported by HRSA to provide training and technical assistance to community health centers. We offer for free our training activities to the 13 plus thousand community health centers across the nation. We specialize in topics related to conditions or social issues affecting those living in public housing or those who are HUD assisted adults or HUD assisted children. But the conditions, the social determinants of health and everything else that is related to low income populations affect not only the public housing residents and the HUD assisted population, but all of those who are served by community health centers across the nation, homeless population, migrant and agricultural workers, the LGBTQIA plus community. So the training is designed to provide all this training, regardless of the special vulnerable populations that you serve. Next slide, please. Just a quick reminder, there are over 1,300 community health centers across the nation. In 2021, the most recent data that we have available, they provided services to over 30 million patients. 458 community health centers reported to be in or immediately accessible to public housing, and they provided services to 5.7 million patients. 108 of the 445 community health centers are public housing primary care grantees, which means that they receive federal funds from HRSA to provide services to patients. And in the same year, they provided services to over 900,000 patients. Next slide. In regards to the demographics, we have 1.5 million residents in public housing. 38% of the households report to have at least one person with disability. 52% of the population are white, 43 are African American, 26 are Hispanic or Latino. 19% of the household report to have at least one person who is over the age of 65, and 36% of the household report to have a child who is younger than 17. 32% of these households are headed by female with female with children. Next slide, please. In regards to the chronic medical condition affecting public housing residents, there is a publication that was released 2 years or 3 years ago. This is a joint publication HUD and the National Center for Health Statistics, that is part of the Center for Disease Control and Prevention, provided this. This report is my understanding that the report is being updated and the latest numbers will be available by the end of this year. But we can see that over 17% of patients who are HUD-assisted adults have diabetes, which is almost twice when you compare them to low-income renters and all adults in general in the United States. There are other conditions that are related to diabetes, like overweight and obesity, and 71%. And this is a number that we have to we have to make sure that we understand because it's closely related to diabetes. 71% of those HUD-assisted adults reported to be either obese or overweight. So in regard, another condition that is, or another condition that is related to smoking, and as we know, we can't worsen symptoms, is those who are currently smokers in public housing. And we have around 1/3 of the population who are current smokers, and when you compare them to the national data on the youth on the healthy people 2030, they are about 2 or 3 times more likely to to smoke when you compare them to the general population. Next slide, please. So next slide. Today we are going to briefly discuss the basic concepts of diabetes. We are going to describe the diabetes prevention program, and we're going to analyze the role of mental health specialists on diabetes prevention. For some of the attendees, this information may be something that you already know, but it's very important that you know that we are on the same page. And on the second webinar, we are going to make sure that we discuss the strategies that we can use to help patients with diabetes, specifically the behavioral health interventions. Next slide, please. We have another poll question, is as part of our team-based approach, do you provide behavioral health services to patients with diabetes? So again, we are going to give around 30 seconds to respond to this question. Thank you, Fide. We can close the poll, and if you can provide us with the results.
Sure. So far we have 94% who said true and 6% said false.
Thank you. Thank you so much. And next slide. So I'm going to turn it over to Dr. Lombardi for a moment. He is going to provide additional information on the behavioral disorders and diabetes measures in public housing and health centers in general. Kevin?
Hi, everyone. Thanks for having me today. So this is an incredibly important condition, and it will be in all parts of your day, every day, diabetes, not just when you're treating patients, but when you're treating patients who are exposed to the risk factors that predispose the development of diabetes. And I'm going to briefly go over some of this data, but before I do, when I was in residency during one of my last shifts on a night shift, my last year, there was a diabetic patient that I saw in the emergency room, and it was just before my shift was ending. After a long shift, I was exhausted. I think I'm bringing back bad memories for Dr. Leon as I mentioned this, but the patient had diabetes and was there for a diabetes-related issue, but I didn't diagnose that. I misdiagnosed them. And when my attending corrected what I had done, the reason he found out, or the reason he was able to get the correct diagnosis, is because he looked at the patient's feet. I didn't take their socks off and look at their feet, which is the first thing you do when you're seeing a diabetic patient. Not the first, but it's part of the initial physical exam. So I'm telling you that to emphasize the point that the little things really matter with what you notice and how you manage this condition. And noticing one small thing or referring a patient to appropriate care within your system can be the difference between catching something before it's too late and being able to manage it while it's still manageable. So anyway, so let's talk about the public housing population. And for those of you who work in centers that are related to public housing, there's the fact that this population has a unique set of exposures to risk factors that predispose the development of diabetes should not be new news, but the degree to which we're seeing differences in the number of diabetic patients and the number of patients with mental health related conditions in public housing versus non-public housing related centers is quite significant. And if you look at this table, I reviewed the data from the UDS data on patients with mood disorders and with diabetes. And these are a couple of important metrics. And what we're noticing here is that the numbers are quite large for diabetes in all of our centers, but they're particularly high for patients or for centers that are related to public housing. And the percent differences is what I really want you to focus on here, is that it's much larger, 58 to 76% difference. So that's a significantly increased burden. And the important thing when we're looking on data is, well, what does that tell us? Well, that tells us that we're getting these patients more often in public housing related connected health centers. But the thing it's also telling us is that these are a unique set of exposures, and these unique set of exposures are uniform. That's what the p-value is telling us. So essentially, what does that mean, unique exposures? It means our patient population is exposed to risk factors in their daily lives that make them more likely to develop that condition. So that emphasizes more than anything the importance of really getting a good understanding of the patient's social context, because the social context is one of the main drivers of this disparity. Also like to point to the difference, particularly in the bottom here. An A1C of 9.0 is quite high. It's very clearly in the diagnosed diabetes, type 2 diabetes realm. I think we're using 6.3 now for diabetes. Dr. Leon, is that correct? So I think it's 6.3. They change it every few years, but 9.0 is quite high. And if you notice the increase in the grantees with the number of patients with this level of diabetes is important. So what this is telling us is not only are we seeing more patients with diabetes at public health related centers, but the diabetes we are seeing is also more severe and more poorly managed. And the main takeaways I'd like you to take from this is, one, understanding the unique set of exposures this population is experiencing in their daily lives. Two, the importance of catching this and managing this early, and that can mean everything from notifying a colleague that you're noticing a physical exam finding or something in your examination or assessment of the patient that makes you think that diabetes might be a risk factor, and understanding the social context. As behavioral health practitioners, the social context of your patients, the cultural context is exceptionally important to their behavioral health. Many of the factors that drive drive those social factors are also influencing diabetes. So these issues are they have a pretty clear confluence, and I'd encourage you all to pay importance to the social determinants of health when you're seeing your patients, and keep this disparity in mind. Thank you, Dr. Leon.
Thank you, Dr. Lombardi. This training is part of the resources that the American Diabetes Association has on its website. This is free, and if you access the diabetes.org website and go to resources, there are some free resources, and this is one of them. There are for behavioral health specialists. And the only thing that you have to do is to register. This is a self-paced training. And at the end, you can get a credit. So I encourage the participants to this webinar to also visit this resource, the American Diabetes Association website, www.diabetes.org. So let's get started, and let's have a very quick discussion on diabetes. And according to the Centers for Disease Control and Prevention and the latest statistics, 1 in 11 American has diabetes today. These numbers are very significant because it shows that this is a public health emergency. And you will see numbers from other organizations saying that every 23 seconds, someone is diagnosed with diabetes in the United States, and every 2 to 3 minutes, someone dies from diabetes complications in the United States. So this is a condition, probably the most chronic medical condition after the cardiovascular diseases and high blood pressure, and they are connected. So we need to make sure that we address not only the metabolism and the symptoms and signs of the condition, but also the complications and the behavioral health aspect of each patient with diabetes. Next slide, please. As Dr. Lombardi was mentioning, this is a condition that also affects minorities in general, and Blacks and American Indians and Asian Americans are more likely to have diabetes when you compare them to the non-Hispanic whites. So those are the type of patients that you also have contact with at the health center level when you have when you provide services to your patients. You'll see that these populations are more likely to go and be served by community health centers across the nation. Next slide. Diabetes, according to the National Center for Health Statistics, kills more Americans every year than AIDS and breast cancer combined. And as I was mentioning, every 21 seconds, someone in the US is diagnosed with diabetes, and every 2 to 3 minutes, someone dies from a diabetes complication. Next slide. When we think about diabetes, we tend to believe that this is a condition that only affects adults, but as we know, we are going to go over this in a moment. There are different types of diabetes, and every year we see more diabetes cases in children, and it's becoming more difficult to diagnose whether this is a type 1 or type 2 diabetes, because now we see children who are obese or overweight who have the type 2 diabetes, and it's more challenging now for clinicians to diagnose and to make and to see the difference or make the differentiation between type 1 and type 2 diabetes in children. Is very important to mention, and these are numbers and the statistics that are really important, that 200,000 American youth have diabetes, then 18,000 are diagnosed with type 1 diabetes every year. There are 5,000 new cases a year of type 2 diabetes. So type 2 diabetes is becoming more common in children. Next slide. When it comes to health expenditure, $1 in $7 the healthcare dollars are spent on treating diabetes and its complications. And the annual healthcare cost for a person with diagnosed diabetes is over 2 times higher than a person without diabetes. Next slide. So let's get into the terminology. And we've been talking about diabetes, and there is also the concept of prediabetes. So we are going to briefly discuss what is prediabetes and what is diabetes. So next slide, please. Even though, I mean, we are going to see the numbers, to diagnose patients with people with diabetes or prediabetes. But in general, when we discuss diabetes, is a term that we use. It means that a person has a blood sugar level that is higher than normal, but it's not high enough to have or to be diagnosed with diabetes. Next slide. Over 84 million of American adults have diabetes, and 90% of these population do not know that they have prediabetes. The reason is that sometimes you can have prediabetes and have no symptoms. So these people are unaware that they are very close to have one of the most frequent chronic medical conditions affecting the US population. Next slide, please. Now, the issue with prediabetes is that prediabetes can lead to type 2 diabetes and all the complications that a patient or a person can have after being diagnosed with diabetes if the person doesn't take care of all the issues, you know, like exercising or eating a healthy diet. So there is a resource, again, on the diabetes.org website, the American Diabetes Association, that we can use for our patients to see whether or not they are at risk of prediabetes. The URL is diabetes.org/risk test. And this is a really nice, this is a very short questionnaire where you can get some results and see whether or not you are at risk of developing or if you are pre-diabetic and you are at risk of developing diabetes. Next slide, please. So we have discussed pre-diabetes. Now, what is diabetes? And diabetes is when, in very simple language, is when you blood sugar levels are higher than normal. There are three types. Types is type 1 diabetes, type 2 diabetes, and gestational diabetes. Next slide. There are other in between type 1 and type 2, there are other diabetes, you know, like the Moody and that. But this is not the. We are not going to get into the difference between the two conditions, you know, and what is in between. What I do recommend is that when you suspect a case, you know, that probably is Moody or anything that is in between, is the opportunity to discuss with someone who is who really specializes in diabetes, and endocrinologist, or someone who can just determine whether or not there is a variation of any of these two types of diabetes. But this is a condition that that involves the whole team, the whole health, the whole team. So if there is any doubt or if there is any complication or anything that you need to discuss with a specialist, this is one of the conditions that you have to do it, and there has to be a team-based approach. So food is related to diabetes. This is a little bit of a pathophysiology. The body breaks down food and we get glucose, and the glucose is sent to our system. The insulin that is produced by the pancreas helps move the glucose from the blood into the cells. The glucose moving to the cells is either used as a fuel for energy or is stored for later use. And if you have diabetes, there is a problem with insulin, but not everyone has the same issue. We are going to see the difference between type 1 and type 2 diabetes. One is there are some autoimmune issues for those with type 1 diabetes, whereas for type 2 is a resistant. Basically, there is some resistance to insulin. So next slide, please.
Actually, Dr. Leon, if I could add a little tidbit that I thought might be helpful that I
please
recently. Fide, can you go back one, please? Just for a second. So when I was learning this concept, I struggled with it. And the way it was explained to me that really helped my understanding early on in my training is to see insulin as sort of like a key and the cell as like the lock. And the insulin opens up the cell for the glucose specifically. So what do you have if you don't have enough insulin or resistance to insulin? You don't have a lot of keys or keyholes that are allowing the glucose to get into the cell. And if you've ever taken sugar and taken a match to it or taken a lighter to it, what you notice is it catches on fire really quick. I do not recommend you do this at home, but it does in medical school, it showed us something, which is sugar is volatile. It causes a lot of problems. It causes a lot of reactions, and if it's not well controlled, those can happen in your body. And if you are having an issue with those keys and that insulin isn't there, then that glucose is staying in the blood system and it's sitting there. And when it sits there, it will damage the vasculature and it will damage the nerves. So it's really an issue of controlling where glucose is and where it's not supposed to be. Thank you.
Thank you, Dr. Lombardi. Next slide, please. So let's move on to the symptoms of diabetes. Next slide, please. So the symptoms include urinating often, feeling very thirsty, feeling very hungry, and patients experience some extreme fatigue. And these symptoms are related to the high level of sugars in the blood, as Dr. Lombardi was explaining. And people who are experiencing diabetes get dehydrated, and by being dehydrated, because they are urinating very often, they are thirsty. So thus the correlation between being thirsty and urinating very often, and also people are hungry because the glucose is circulating in the blood, but it's not getting into the cells. So as a result, people, even though they have glucose circulating, the cells are not getting the energy or the fuel that they need, and therefore they send a signal to the brain, and the brain basically says to the body, hey, we need food, we need energy, we need fuel. So those are how the symptoms relate to the level of glucose in our body. There are some complications as well. I mean, if people do not have the appropriate treatment, people can get blurry vision. They have cuts or bruises that are slow to heal. There is weight loss, and there is tingling, pain, or numbness in the hands and feet. Specifically, this is related to what Dr. Lombardi was saying about the neuropathy and all the vascular issues of when you have high levels of glucose in your system. Next slide. Next slide, please. We are going to briefly talk about the types of diabetes. Diabetes 1 or type 1 diabetes is when the immune system mistakenly destroys the beta cells in your pancreas that make insulin. So there is no production of insulin, or there is very little of insulin produced. There is no, the glucose circulating cannot get into the cells. And that is often seen in children. Next slide, please. Type 1 diabetes. There is still some conversations and some debates over whether or not what is the exact cause of type 1 diabetes, but it's been considered an autoimmune disease that destroys some of the cells in the pancreas. But what is really important to notice as well is that we associate type 1 diabetes with children, and type 1 diabetes is, I mean, you can see patients who have been diagnosed for many, many years with type 1 diabetes. And when you see them, they are adults or older adults that we think that probably the patient is going to have a type 2 diabetes, but the patients have had diabetes for many, many years. Next slide, please. The type 2 diabetes is basically when the body doesn't use insulin properly, and this is insulin resistance. We see that patients are obese and overweight, and the amount of insulin produced by the pancreas is sometimes not enough as well, and what is produced is not well taken by the cells, and as Dr. Lombardi explained, these keys are not enough or not opening the channels so glucose can get into the cells. Next slide, please. So there are some risk factors. Some are modifiable, some are risks that we cannot modify. Those who can really we can modify are if the patient or the person is overweight, or the person is obese, or if there is physical inactivity. There are others like age and race and ethnicity and family history of other conditions that cannot be modified. So we can focus on what we can modify, what we can do to prevent either prediabetes or diabetes. And that's the reason why the treatment also, in addition to the drugs and medications, we also focus on the diet and the need of patient to exercise, to improve, to keep the weight or the ideal weight, and at the same time to improve the physical activity of these patients. Next slide, please. So now we are going to get into the numbers. We were talking about A1C, and anything that is below 5.7 is considered normal. What is between 5.7 and 6.5 is considered diabetes, and over 6.5, the patient or the person has diabetes. In regards to the FPG, if the FPG is low, under 100 milligrams per deciliter, that is considered normal. And if it's above, it's between 100 and 125 is considered prediabetes, and anything above 126 is considered diabetes. Same with the OGTT or the glucose tolerance test. Anything that is below 140 is normal. Over 140 and below 200 is considered prediabetes, and anything that is above 200 milligrams per deciliter is considered diabetes. Next slide, please. Now, in regards to gestational diabetes, there are some female patients who develop diabetes during pregnancy. Sometimes the glucose level returns to normal after giving birth, but the patient is a high risk for developing type 2 diabetes. And if the blood glucose doesn't return to normal, then this person is diagnosed with type 2 diabetes. Next slide. Next slide, please. We are going to briefly talk about diabetes complications. So if people are not treated, or people are not following their medical advice or the medical recommendations over time, they can have some complications, and they can develop some nerve damage, kidney damage, eye problems, amputation, and heart disease and stroke. I would like to highlight here that the first cause of amputations in the United States is because of diabetes. So we need to make sure that we discuss with our patients the need to keep their feet clean, and as Dr. Lombardi mentioned, his experience with his patients is that we need to make sure that we also have the feet of our patients seen, and either by a nurse or the clinician or a podiatrist or whomever is part of the team, just to make sure that there are not other complications. Next slide, please.
And just to briefly add, Dr. Leon, the thing that catches me here that folks may not notice is that what do all these body systems have in common? And nerve damage, kidney damage, eye problems, amputation is all related to dysregulation in the vasculature, and particularly the very small capillaries. So these are the places where the sugar does the most damage and causes issues with circulation. And just, I don't know if anyone's ever met someone on dialysis. And the burden of diabetes on kidney disease is incredibly severe in this country. And dialysis is tough. It's difficult on the body. It's hard for patients to go through. And that just emphasizes what the effect of this condition is. And it really is life-changing if it's not managed appropriately or caught early.
Correct. Thank you, Dr. Lombardi. Next slide, please. So the recommendation for people with either prediabetes or diabetes are basically the same. We have to lose some weight. In the past, I remember we were talking about 5%. The new recommendations are talking about 7% of your weight if you are either overweight or obese, to increase the daily physical activity and exercise at least 5 days a week for 30 minutes or more. Depending on whether the patient or the person has any other conditions, we need to make sure that the person is able to exercise, develop a meal plan, and take the medications. Next slide, please. It's really important to stay active. By staying active, the body is more sensitive to insulin, and the insulin can work better. The cells take glucose out of the blood during exercise, and exercise can improve our mood. So this is very important, specifically for those behavioral health specialists that we have. You know, also the recommendation that not only to eat healthy, but to exercise to improve or to decrease the incidence of any mood disorders in patients with diabetes. Next slide, please.
You know, Dr. Leon, I read a study recently, or within the last couple of years, that the effect of, when measured, the effect of antidepressants and regular exercise, they have about the same effect. So this is one of those times where you can really hit two birds with one stone as far as preventing diabetes and helping to protect your patients from the effect of mood disorders.
Thank you, Dr. Lombardi, and you are totally right. An exercise is going to improve, you know, any anxiety disorder or any other behavioral health condition or mental health condition, regardless of whether or not the patient has diabetes. So the recommendation is for all patients, you know, to promote a healthy living, because sometimes we have patients with diabetes and who are depressed, and we don't know whether the patient was depressed first and the patient got diabetes, or because the patient had diabetes, you know, the patient got depressed. So it's
chicken and egg.
That's exactly right. So regardless of whether or not our patients have diabetes, exercise will improve the mental health status of our patients in general. Next slide. So recommendations about the type of activities that people can do are lifestyle activities, outdoor activities, just to walk, a brisk walk for 30-45 minutes, aerobic exercise, strength training, balance training, flexibility. The recommendation is to do a little bit of everything, you know, I mean, to combine what is aerobic exercise with strength training and balance training. So there is first motivation. The patient don't get into the routine of doing exactly the same every single day of the week. But at the same time, it helps patients, you know, and there has been some studies that those who do some strength training, you know, are very or responds better to treatment when they have diabetes. Next slide. In regards to meal planning, there is a website, is myplate.gov, if I'm not mistaken. That's the website where you can find all the resources about for patients with diabetes and what they need to eat, how often. But in general, the recommendation for all patients is that they have to fill half of the plate with non-starchy vegetables, 1/4 of the plate with protein, and the other quarter with grains or starchy vegetables, fruit and yogurt. Sometimes I get the questions about the starchy vegetables, and we're talking about potatoes and sweet potatoes. So those are considered starchy vegetables and not the green non-starchy vegetables that we can have, or we can fill the plate for on half of the plate with the non-starchy vegetables. Next slide, please. In regards to medications, there are several oral medications and pills for diabetes. The most common one and the very first one that is recommended if the patient doesn't have any contraindication is metformin. We have insulin and other injected medications. But in general, since this is a 101 diabetes approach, we are not getting to the treatment plans for patients with diabetes. But there are different options that patients can discuss with the clinicians, and these are going to be the main tools that we are going to have in addition to an exercise plan and develop a healthy diet for our patients. Next slide. When we talk to our patients, we need to make sure that they develop what is called SMART goals. SMART stands for specific, measurable, attainable, realistic, and time specific. We cannot ask a patient who is obese to lose 7% of his or her body weight in a week. That's unattainable, and we need to make sure that we follow a plan, that we individualize our plans. Not all patients are equal, so we need to make sure that we are providing these treatment guidelines and recommendations to patients based on the specific and particular needs of our patients. Next slide, please. When we have a patient, and especially if this patient has been diagnosed with diabetes first visit, and there are several other resources I would like to mention on the American Diabetes Association website. We were talking about the take the risk test for diabetes or for pre-diabetes, but they do have they have a food hub in addition to the MyPlate website that I mentioned, and they have a hotline, the 1-800-diabetes, for resources. If you're looking for resources for your patients, they can help you, find the resources that you need for any patient with diabetes. Next slide. In regards to the MAP or the Measure Act partner, this is when and how patients can be referred depending on why they are contacting us. Yeah, this is a very elaborated slide, so we are going to send the slides to all of you, but this is describing who, where, in what part of the clinical setting the patient can get help, and where this patient can be taken from the receptionist to the nurse to the physician or to any of the other person who is part of the medical team. Next slide. Briefly, the Diabetes Prevention Program. This is a program developed by the Centers for Disease Control and Prevention. There is the Diabetes Prevention Program, and there is another one for patients who are actually diabetic. So it is a very intensive course, just helping patients with lifestyles and changing the habits to make sure that they do not develop any complications, or they do not develop diabetes. In this case, we're talking about the Diabetes Prevention Program. Next slide, please. To join the Diabetes Prevention Program, there are some requirements. The patient needs to be at least 18 years or older, has to be overweight. The patient doesn't need to be, there is no diagnosis of type 1 or type 2 diabetes, and the person is not currently pregnant. So the person needs to meet one of the criteria below, diagnosed with prediabetes or previously diagnosed with gestational diabetes, or the patient had a high risk result on the prediabetes risk test. Again, the prediabetes risk test can be either accessed through the American Diabetes Association or to the Center for Disease Control and Prevention, cdc.gov, prediabetes/risk test. Next slide, please. This is part of the curriculum and what the Diabetes Prevention Program covers for patients. This is a one-year program, and it's very helpful. We have had some very good results from patients, very good feedback, and it's it is a program that is recommended for patients from the very beginning when you have a patient with prediabetes or patient who has had gestational prediabetes. Next slide, please. So just quickly, we are going to discuss the role of behavioral health specialists in diabetes prevention. This is just the introduction because we are going to get more into the details in our next session. But next slide, please. Next slide, please. So there have been some studies showing the role or why it's so important to include the behavioral health specialist with a patient with diabetes. This is a study that was conducted 1 or 2 years ago, and it shows that it really improved the clinical outcomes of patients who also receive advice and recommendations from behavioral health specialists. There is a very glycemic control. There is a change in body composition, so patients are losing weight. There is an improvement even in sleep apnea or development control, or if the patient has depression or anxiety or is at risk of their developing depression or anxiety, there has been some improvements. And then the health outcome is that there is a better quality of life and decreased mortality in patients who have been or who were part of this study and received behavioral health intervention. Next slide, please. So sometimes we are asked, so how we can involve a behavioral health therapist or specialist, so they can help patients to treat their eating, to track their eating patterns, change their environment to avoid overeating, to help them and motivate them to increase the activity level, to create an exercise plan, and to set realistic goals. We just mentioned the SMART goals, and something that is a plan that is individualized and that is not something that is not realistic for our patients. Next slide. There is next slide, please. So the behavioral therapy helps our patients to make small changes, to self-monitor, to screen for depression, and to prevent recurrence of any anxiety disorder or depression, or that the patient start eating or overeating. Again, there are other conditions that we can mention briefly as well, like some patients who are on insulin, they when they see that they are either gaining weight, they adjust the amount of insulin that they are getting, so they can either lose weight or gain weight, and those are things that we need to be very careful and monitor. And that is a behavioral, the behavioral, what a behavioral specialist can help patients. In addition to screening for any of the for depression and or anxiety or any of the conditions that can affect the outcome of a patient with diabetes. Next slide, please. This is my contact information. I would like to thank again Dr. Lombardi for joining us this time and sharing not only the numbers, but his experience as a clinician. You have any questions, please let us know. And next slide, please. This is the information about the second webinar of the series. It's going to be on November 3rd. It's going to be specifically on the role of the behavioral health providers in diabetes prevention and management. If you share the URL, which is in the chat and the chat box. And if you have any questions, please, I'm not sure if we have any questions.
Not at the moment, Dr. Leon.
Yeah, I see a comment from Walter. 5 to 7% of weight loss and 150 minutes of moderate activity lowers the risk by 53%, and patients over 60 is reduced by 75%. Thank you, Walter, for the information. Serena, thank you as well for being with us. And again, if you have the time, please participate on the webinar on November 3rd. And we would like to ask you to complete the survey that we have after this webinar. It's our post-survey webinar. So if you have 1 or 2 extra minutes, please make sure that you complete the survey.
And thank you all for your service. It's incredibly important work that you do, and we certainly appreciate all the time you put into taking care of your patients and the time you took to listen to us. Thank you.
Thank you. And you can also visit on our website. We can find additional resources and all the training materials that we have developed for community health centers in general. We cover other conditions. We are covering COVID-19, anything that is related to emergency preparedness, diabetes, which has been an HHS priority. We have materials on smoking cessation, which is a priority for those living in public housing. Behavioral health issues also affecting those living in public housing. You can find training manuals, toolkits, live activities, interactive maps where you can find the location of your health centers and the closest public housing development in case you are interested in reaching out to these populations. Next slide, please. You can contact us. This is our team and our contact information. And again, thank you so much for attending this webinar. Have a great afternoon.